As a payer, uh, how do you see the approval of these drugs changing the landscape in America in terms of kidney disease and in terms of treatment of the anemia of kidney disease? Is this going to be a train heading down the track right at the insurance company, or is this already been discounted in your calculations? And what are you going to approve?
No, I think they certainly will change clinical management, at least for a subset of patients with anemia of CKD. For example, um, if you have a patient, if you have the right patient profile, meaning a patient that has suboptimal responses to ESA or ESA resistance, those patients will certainly benefit. So as a health plan, I think we recognize that clinical quality is of kind of paramount importance. And we also recognize, and I mentioned this earlier, that we know that anemia of CKD seems to be undertreated. And that undertreatment of anemia tends to lead to total increased healthcare resource utilization because people are either crashing to the hospital, needing blood transfusions, et cetera. So I do think there'll be a change in clinical management. Clearly, there are patients who will benefit from this, especially given the relative known black box warnings of ESAs. So people who have, underlying solid tumors, head and neck tumors, et cetera, uncontrolled hypertension, history of strokes. Again, I think that these patients will certainly benefit, and as a health plan, there'll be a pathway to have these people on these agents if need be.
So that brings up an interesting thing. So when I think about using these drugs in the non-dialysis population, when I prescribe an ESA to them, I have to warn them that those drugs can double their risk of stroke and increase other thrombotic events. None of that signal came out of the placebo-controlled trials with roxadustat. And yet, sort of what you allude to is that I may have to have really kind of a compelling reason. Oh, you've already had strokes, so now you don't get an ESA. You don't have to go on ESA before you can get the roxadustat. Do you think it will come to that? Because what I see is this opens the door. A lot of patients in the nines would say, I'd rather not have an ESA at all if that's the risk that it's carrying. But I say, oh, now here's a new treatment that doesn't carry those risks. Now I can start treating these hemoglobins in the nines with more confidence that I'm doing a safer job of it.
If the risk signal is that much better, are you really suggesting we just take the ESAs and consign them to the dustbin of history?
I certainly the improvement in cardiovascular events in the incident dialysis patients compared to ESAs say that ESAs are going to be in the dustbin of history, because although the cardiovascular risk was about the same in prevalent patients, there's many reasons for that. The ESAs may have already knocked off the vulnerable population. But all prevalent patients come from incident patients. So if you just started treating everyone who starts on dialysis with roxadustat or similar agents because they're safer, in 5 years, everyone will be on them.
Stanley, if I'm a patient and I'm sitting across from the brilliant Dr. Coyne, and he tells me, you could take this drug, but it increases your risk of heart disease and stroke, or you can take this drug and they're both really effective on your hematocrit, which you really need, but no stroke. That's I guess I shouldn't say no brainer given the stroke reference here, but it's pretty clear to me. I want this drug. Are payers going to let you skip the ESA step altogether?
So if I were sitting across from the brilliant Dr. Cohen, I would also as well understand his analogy, but from a populational standpoint, this would have to be probably fleshed out a little bit more to help us really understand what this looks like in terms of total cost of care and the total patient experience. We talked about this earlier. And at this point, most payers don't know the price or cost of what these agents will be as compared to the total cost of care of what we know now is standard of care, which is ESA therapy and iron. So this is one that's going to be determined as this drug is rolled out, and it will be based on several factors, including drug pricing, but also, like we talked about, the other variables that will affect patient care. One other thing I should mention too, a lot of payers now are going toward this idea of value-based drug pricing, and it's gained some traction, I think, in the past few years. And what that means is that a contract or cost of drug is tied to a health outcome. And this gets back to that whole, you're treating the whole person and their total healthcare. And so in exchange for some price, you'll then agree upon a clinical outcome. And so you can make it be something as simple as, maintaining hemoglobin more than 10 on this drug without having, a stroke rate of X amount. And then that's how reimbursement is decided. So I'm saying all this to say, because these drugs aren't on the market yet, there are several different strategies around making sure members get the appropriate care at the appropriate time.
All right, Drs. Coyne and Provenzano, what more do you think you need to give the payer population, not necessarily Dr. Crittenden, who's obviously brilliant and sympathetic, but everybody, to make the case for these drugs if you think it needs to be made? What kind of education?
Well, let me just build on what Stanley said, because this is a frustration. So, and not, not with me, but I think physicians as a whole. So, as I mentioned, at least the data for roxadustat has been presented. Largest anemia trial shows without a doubt in incident patients, to Dan's point, 30 to 34% decrease in MACE. Now, what does that mean? So from a health economic perspective, it means there's going to be a savings from these people, obviously not having strokes or cardiovascular events. From a societal perspective, it means they're less likely to need rehabilitation, nursing homes, can spend time with their family. I mean, when you start putting the pieces together, it's going to be a hard case to deny care if the data is accurate, but data is data. But to your point, again, much like we learned with Treat and Inquire, there's a whole bunch of other questions, right? What does chronic long-term exposure to these products bring? Are there additional benefits? We have already seen that it may delay progression. So again, from a payer perspective, delaying progression is the holy grail, right? From a nephrology perspective, that's the holy grail. Delaying or preventing exposure to transfusions, that's going to have a positive benefit on transplantation. There is now evidence that there's direct positive impact on endocardial cells. I mean, there's a whole list of other things we can see on the horizon on the positive side, but let's not again forget that on the negative side, chronic exposure, we've learned hard lessons in the past that we thought we knew with chronic exposure.
We're not going to get that data from phase 3 trials, right?
No, we're going to need 3B trials and phase 4 trials and probably a registry. We don't know what the FDA is going to say, but they may demand a registry. So there's a lot of stuff we still don't know.